Welcome to the Nutrition Hero Podcast with Dr. Brad Watts, making heroes in functional medicine and clinical nutrition. Now, here's Dr. Watts.
What's up, Nutrition Hero family? This is Dr. Brad Watts, and you're listening to another episode of the Nutrition Hero Podcast, where we're celebrating both the art and the science of functional medicine. Today, as promised, we're going to be talking about the female sex hormone pathway. And because today is Female Sex Hormone Pathway Day, you're going to get both the science and the art of this, because I'm telling you, just when you think you got this puzzle organized, it changes. That is the crux of the matter with treating people that are dealing with dysregulation or issues with their female hormone cycle. Now, ask me how I know. I got put through the ringer so many times in helping people organize this type of a situation. When I was a new doctor, here's the backstory, okay? So when I was a new doctor, functional medicine provider, I was working in a clinic where I would treat all the patients. I didn't necessarily bring the patients into the practice. I would just treat them and do the follow-through. So how it was set up is I was taking a patient from a female doctor, and the female doctor was somebody that was very charismatic, a very good leader, and somebody that the women that came into the practice looked up to. The women that came into the practice wanted to be, and so they would connect with her, and then she would say, by the way, you're going to be working with Dr. Brad Watts. And they would say, all right, that sounds great. Show them my way, right? And so what would happen is they would show up in my office, and I would see the notes from the doctor that was basically doing the screening and examinations at the beginning, and they'd say, all right, so here's our project. We're going to organize the female cycle. We've had dysmenorrhea or amenorrhea for however many months, and things are not going well. Every time my cycle happens, I feel bloated and I get headaches and migraines and puffy and I don't feel well. And I'm sitting there supposed to help them get better, right? Like, oh my gosh. Yes, I grew up with sisters in my family, but I wasn't like a hormone wizard, right? And so in the situation, it's like you got to either sink or swim, better be proficient or get eaten, so to speak. And so I learned real quick the female hormone pathway like the back of my hand. And the funny part is even when you know it, it doesn't always help you. Even when you know it, it doesn't always help you. So one of the things that the doctor that I learned from, most of the female hormone pathway situation that I learned from this doctor. And she said one thing that I'll never forget. She said, it's like a puzzle that never stops moving. Okay, well, that stinks, right? It's a puzzle that never stops moving. How do you solve a puzzle that never stops moving? You just got to work smarter and faster than the puzzle is. And so one of the things that you got to do is you have to be able to predict. You have to know where the puzzle is moving, and it telegraphs itself. So I'm going to give you some clinical pearls today that are really like the art of functional medicine more than anything when it comes to learning and being able to intelligently discuss female hormones with your patients in a way that brings some clarity to the subject, because even they don't understand. Why? Because they're learning from doctors that don't understand either. And so this is where you come in. So bust out your number 2 pencil, the orange number 2 pencil with the yellow eraser on the top. Bust that out on a piece of paper today, because you're going to be writing and erasing, I promise you, more than once. Okay, so what would be even cooler is if you just Google female hormone pathway and pull up a diagram that shows you a 28-day cycle, charted out with estradiol and progesterone, FSH and LH values, so that we can see what we're talking about here. Because we're going to go through this review, and even though this is a map, this map is never 100% accurate. It's never 100% accurate. Everybody's a little different. Every female patient that you have is going to be a little different. You might find 1 in 100 that's like, yep, 28-day cycle, everything happens exactly as it says on paper. Now, there are ways that you can organize this testing-wise. Saliva test. You can do a month-long ovulation test with ovulating female hormone test. And it's awesome. You can chart all this stuff out, compare it to normal, and figure out, and I say normal in quotations, okay, and figure out how to best help your patient base. But what's cool is that if you know what it looks like, you can just draw it and you can talk about it and say, all right, so we need to start tracking either your body temperature and doing basal temperature rates so that you can map out where they are in their cycle, which sounds like a lot of work, and it is, or you can test. So let's get to it. So we're going to start in day 0. Day 0 is the onset of menses, so menstruation, day 0. Day 0. Day 28, we're going to talk about at the end of the cycle, and then it's going to cycle back over to day 0 again. So if you're drawing this out, on one side of your piece of paper, put day 0, on the other side, put day 28. Right in the middle is going to be day 14, and that's really, day 14 is really going to be the time that we are most interested in. So let's assume that somebody is menstruating for between 2 and 6 days. We'll just call it that, 2 and 6 days, okay? So it could be light, 2 days, could be more of an extended situation in 6 days, excuse me. But 2 to 6 days. You're going to shade in the first 2 to 6 days on this chart on the left-hand side. I'm going to say menstruation. During menstruation, what's happening is we are having both estradiol and progesterone levels on the very low end of the concentration spectrum. And that's because it's a reset. This is how the female hormone body is resetting. And what's cool is that if we can map this out the right way, you'll understand exactly what's happening as far as detoxification of these hormones. Okay, so we're going to talk about weight loss. We're going to talk about migraines. We're going to talk about puffiness, if you want to talk about it that way. But what's taking place here is estradiol values are on the low end. Estradiol values are on the low end. Progesterone values are on the low end. And as we're going through the first 14 days, so to put 14 day in the middle, draw a dotted line, vertical dotted line, which is kind of the cutoff from the front half and the back half of the female cycle here. Estradiol is going to be rising from low to high during these first 14 days. Progesterone is just flatlining for these first 14 days. Estradiol, estrogen, E2, estradiol is rising for these first 14 days. Progesterone is flatlining. When estradiol is rising for these first 14 days, people are starting to feel more normal as a female, starting to feel more normal again after the onset of menses. And that's because the estradiol values are hitting those estrogen receptor sites, and we're getting the effect of that hormone once again. And as we hit that 14th day, what's going to happen is estrogen is going to plummet. Estrogen is going to plummet because we're ovulating. So estrogen, again, what is it doing? Is it's rising for the release of an ovum, right? Or an egg, if you want to look at it that way. It's rising to release of the egg. The egg comes out on the day 14. This is just a perfect cycle, okay? Egg comes out on day 14. Estradiol crashes, and now progesterone is on the move. Progesterone is climbing. Progesterone climbs because we are going all about the uterus here, trying to make sure that if that egg gets fertilized, that the uterus is ready to get implanted, okay? And so what's happening here is progesterone rises the second half of the cycle. Progesterone peaks. Estrogen is making a comeback here as well. Estrogen follows it, mimics it. Then they both plummet on day 26, 28, somewhere in there. All right, so we should have two mountain peaks here. One's red on the left-hand side, one's blue for progesterone on the right-hand side. And what's cool is that they're both arriving back at their baseline of near zero at the end of the 28 days. Okay? Now, estrogen and progesterone are the results of two hormones coming out of the pituitary called FSH and LH. So if estrogen rises on the front end of the cycle, what happens with FSH? FSH rises during menstruation. And then FSH rises one more time, days 12 to 14. So there's two things in a female hormone cycle that get a little convoluted that we're going to talk about here. One is a positive feedback loop, and one is a negative feedback loop. Positive feedback loop and negative feedback loop. Negative feedback loop shuts the faucet off, while a positive feedback loop turns the faucet on. So days 12 to 14, this is the kicker. This is, if we can get this, if we can understand this, This is going to solve a lot of the problems that you see in clinical practice with how to create predictability, not just in detoxification, not just in organizing a female hormone profile, but also in helping your patients feel well, okay? Days 12 to 14 are the monkey wrench in dealing with a menstruation cycle, days 12 to 14. Because days 12 to 14, you have an activation of a positive feedback loop, which means more estradiol and progesterone show up, feeds back to the pituitary, and it causes even more release of FSH and LH. Instead of shutting it off, it turns it on faster. Okay, so days 12 to 14, positive feedback loop. This is crazy, by the way. So think about this, okay? Days 12 to 14, when FSH and LH days 12 to 14, when estradiol and progesterone are present in the bloodstream, they trip a wire in the brain that sends a signal from the hypothalamus to the pituitary, and it says, you know what? We really need more FSH and LH. And so that's where estradiol peaks for ovulation, and that's where progesterone just takes off screaming for the mountaintops here, so that we can create viability for that egg to implant. Now, 12 to 14, days 12 to 14, positive feedback loop. Just make a note about it. Google it later so that you can get more clarity around this. But this is the key, okay? This is the monkey wrench that most people don't understand, all right? The rest of the month, days 0 to 12 and days 15 to 28, the rest of the month, those hormones, estradiol and progesterone, act in a negative feedback loop fashion. Negative feedback loop fashion. So that means that FSH and LH coming out of the pituitary are only at their strongest days 12 to 14. Only at their strongest days 12 to 14. This is so important. This is so important because if you have somebody that cannot detoxify of estradiol, progesterone appropriately, and they're getting migraines during their cycle, okay? Well, I always get a migraine before I ovulate. How many times have you heard that in clinical practice? Often. I always get a migraine before the onset of my menstruation. How many times have you heard that? Often, right? And so if we can understand that the difference between positive and negative feedback loops, then what's going to happen is you're going to be able to telegraph this, basically write it down for the patient and show them this and be like, hey, here's what we need to do. We need to figure out how to get your body processing hormone at a faster rate during these days right here, because this is what's happening. Okay, you need to Google this so you can actually see a picture of it, okay? Positive feedback loop in a female hormone cycle, days 12 to 14. This is the key. All right, so I'm not going to belabor the point anymore, but that's the key, okay? So when we talk about these hormones rising and falling, really what we're talking about is the brain trying to conduct an orchestra, and sometimes the orchestra doesn't want to play the same music, right? So if you have inappropriate, maybe she has cysts. Maybe we're dealing with cysts. Maybe we're dealing with an inability to create normal levels of estrogen. Maybe we have too much estrogen, like some ectopic situations happening. Or maybe we have some cysts that are producing estrogen, not just testosterone. And so what happens is all of these hormone variations and the actual physical anatomy variations will change this hormone cycle. But if you know what home base is like, if you know what it looks like, okay, that gives you an opportunity to always go back to home base, where to start in order to organize this hormone cycle from the beginning. Okay, so with that in mind, again, Google it, make sure you get the pathway, print it out if you have to, laminate it, just keep it in your office. It's a cool tool in order to be able to show people what's going on. So we're going to assess it by doing the 30-day saliva test. 30-day saliva test. And it's awesome. And it works really well, and it maps it out just beautifully. But it takes diligence, and it takes somebody that's actually willing to follow through with it. Okay, not for everybody, but somebody's going to get value out of this. So remember that. Okay, so I use the one from Diagnostics, and it's awesome. Works really stinking well. It'll map it out, and then you can compare your map to the map that ultimately your patient produced with the saliva panel. And it's pretty cool. So what are these hormones made out of, by the way? What are these hormones made out of? They're all made out of a cholesterol backbone. And so when we look at cholesterol backbone, what's happening is essentially we need to make sure that the patient is dealing with healthy levels of cholesterol. So when somebody comes to my office and they have cycle problems, or they are gaining weight and they got diagnosed with PCOS, or I would keep having ectopic pregnancies, or whatever it might be, what we want to do is we want to figure out where to start. So we're going to start with a cascade pathway here now that you understand at least a little bit about how to map out the female hormone cycle. The cascade pathway begins with cholesterol. Cholesterol funneled into pregnenolone, pregnenolone into progesterone. Okay? So progesterone shows a pathway where we can go into dealing with adrenal hormones and all that kind of stuff, which is cool. You can also take pregnenolone and shove it into DHEA, and DHEA gets funneled into estradiol. And so when we look at, hey, you don't have enough estradiol or you don't have enough progesterone, we have to understand that stress hormones are going to funnel progesterone, the building block for progesterone, called pregnenolone. Stress is going to funnel those toward cortisol production. That's going to steal progesterone. If you steal progesterone, what's going to happen to your female hormone cycle? Well, it's going to stink. It ain't going to do its job at all. Not at all. And so stress plays a key role in this, right? So does cholesterol. So the reason I'm bringing this up is you might have a patient who's 45 years old, gets put on cholesterol-lowering medications, and all of a sudden they feel like a crazy person, right? Why? Because they can't create progesterone. If they can't create progesterone, they're not going to be creating their adrenocorticotropic hormones the way that they're supposed to, certainly, and they're also not going to be creating cortisol the way that they're supposed to. And it's crazy, and people feel crazy because they don't have that epinephrine that they used to have, because they don't have enough progesterone to funnel towards its production. Right? Interesting, though. It's so interesting to me. And one of the things that takes place is we get stuck as functional medicine providers by just saying, oh, I don't know, let's try this product, let's try that product, instead of saying, let's draw the map and let's figure out what's going on here with this person. So when we look at the cholesterol synthesis pathway here into estradiol, if somebody's got a cholesterol value of 107, do you think they're going to be creating estrogen the right way? Probably not. Could they be dealing with low estrogen side effects? Absolutely. Absolutely. Right? And like what kind of low estrogen side effects? Hot flashes, certainly. Irritability. Metabolism can slow down. And so what do they go do with the doctor? Go back to the doctor, and the doctor doesn't look at aldosterone. They don't look at progesterone. They're not looking at pregnenolone. What are they doing? They're just giving them estrogen because they feel like, well, you have low estrogen side effects, might as well just do it and see what happens. They show up in your clinic, you can't do that. You got to map it out. So cholesterol, pregnenolone, pregnenolone, progesterone, progesterone, aldosterone. Right? I think I misspoke earlier and I was talking about epinephrine here. But epinephrine's going to get triggered by a different pathway with estradiol, so hang on with that one. Okay? So cholesterol to pregnenolone. This thing is called a pregnenolone steal. When we start stealing pregnenolone away from creating sex hormone and we start using pregnenolone to produce cortisol, well, that stinks. That's a tough spot for the patient to be in. Really tough spot. And so as we map it out with the patient base, we need to figure out, what do they have? Do they have low progesterone? Do they have low estradiol? Both? Low cholesterol? Or all three? What do they have? If we know that, then we can figure out how to make the orchestra play the same song again. But we have to know what are all the pieces of the puzzle that they're dealing with. So most of the time, when you're dealing with somebody that has, well, let's say this, they're under 55 years old, they don't necessarily have chronic disease yet, but they don't feel well. Maybe it's a migraine situation. Their hormones are going to be large and in charge. It's usually not a lack of hormone that's present. This is a clinical pearl for you, okay? Usually what the issue is lack of detoxification of the hormone. Lack of detoxification. And so if we look at lack of detoxification, then we start, looking at what are some of the cofactors needed for detoxification. Well, stabilize blood sugar. So you start there, right? Oh yeah, this patient has PCOS, so blood sugar is totally up their alley. right? What else do they have as far as cofactors for detoxification? What's their methylation ability look like? Their B12 level? Do they have B6? Right? Are we looking at so it's called cytochrome P450? Are we looking at cytochrome P450 activity under the right lens? And if you don't know what that means, you don't actually have to know what that means. You just have to know, are they detoxifying appropriately? What do the liver transaminases look like? AST, ALT, GGT. What's their bilirubin score look like? And these are ways that we can analyze, all right, interesting. You feel like crap when you have this certain time in your cycle. Let's get your blood test done at that certain time in your cycle. Let's see what your detox capacities look like, right? That's the type of detective work that you want to be doing with these people, okay? So that's the type of detective work. Because when we look at this, if they have high cholesterol and they can't detoxify, maybe they have fatty liver changes. If they have low cholesterol, right, and their progesterone values are like super low, cortisol is super high, then you have a stress mechanism to figure out, whether it's chemical, psychological, or physical stress. You have a stress mechanism to sort out to help that person feel better. Hint, chronic exercisers. Hint, chronic exercisers. Low cholesterol, low progesterone, high cortisol. Oh yeah, that person's a mess. Okay, that person, you need to help them sort that out, and you might actually have to tell them to chill on their triathlon training. Chill out on the triathlon training. How about this one? Polycystic ovarian syndrome. So here you have somebody that is dealing with blood sugar instability, maybe diabetes, maybe not, maybe just hypoglycemia, precursor for type 2 diabetes, and oftentimes. And maybe they have polycystic ovarian syndrome, and they're dealing with insulin surges because they're not eating appropriately. Right? Or maybe they're taking insulin. Well, they're funding testosterone production directly every single time we have an insulin surge through an enzyme called 1720 lyase, L-Y-A-S-E. 1720 lyase. And that's the one for you to know, because most doctors don't know about 1720 lyase. They just know that, well, high blood sugar causes PCOS, which means I'm going to give you metformin even though your A1C is 4.7. Right? That is madness, by the way. What you're going to do is you're going to help them detoxify of that buildup of testosterone by supporting their phase 1, 2, and 3 liver detoxification mechanisms. We talked about this maybe last week or a couple weeks ago, but like doing a metabolic clearing program with them, something that's gentle that allows their detox pathways to open by supporting their natural ability to do that. And then control their blood sugar. Bring it back up. Don't hammer it down. Metformin's just going to make it worse in the long run. It's insane. So it's like when a doctor gives a patient metformin for PCOS, it's like saying there's only one reason for high insulin. There's only one reason for high insulin, and that's high blood sugar. That's ridiculous, right? That's like a classic, I don't understand physiology statement right there, but that's the standard of care right now. And so you have a huge opportunity as a functional medicine provider to make a huge difference for some lady that you're about to meet this next week. And she's going to walk in and you're going to go, you have PCOS, huh? That's a diagnosis. Yep, doctor has me on metformin. And you're going to look at her blood chemistry. Her A1C is going to be 4.7. And you're going to go, what in the heck? No wonder you feel like crap, right? No wonder you feel so terrible. And so this happens time and time again. I bet I went through a dozen of these cases before I understood it. And I only understood it because there's doctors that are wiser than I am that were like, hey, what are you doing, knucklehead? Here's how you fix this, okay? And what's awesome is that once you understand this mechanism, you're going to see it on people as they walk into your clinic. You're going to see it. Facial hair. Whiskers. Right? Can't hide it. Nobody hides them forever. I don't care if you get your lip waxed, your sideburns waxed, whatever. You can't hide it forever. So always look at the forearms. Always look at the chin. Or right where, right in the front of the throat, like right over the thyroid, okay? So even if a lady waxes her face, they never wax over their thyroid, right? And they never get rid of the hair on their arms. Look for it, okay? Look for it, because you're going to help that person reverse that hormone situation. Yeah, they have like rogue tissue. Cool, okay? They have cysts. Doesn't mean the cysts have to control their life, right? So metabolic clearing is the way to go when you see this in action, and then organizing and controlling the blood sugar in a way that allows the patient to promote better function in the long run. Polycystic ovarian syndrome has wrecked a lot of people's lives, from reproductive capabilities and all of this stuff. It's insane. Okay, so let's talk about reproduction here as well. Let's say you have a female that cannot get pregnant, and they check the guy. It's not a problem with the guy, okay, but it's just a problem with the rhythm of her cycle. What are you going to do? Promise me, just because you listen to this podcast, promise me you are going to do the long, drawn-out 30-day female hormone pathway profile. Do it. Long and drawn out, okay? You have to. What you're going to find is going to be amazing. No other doctor is going to do that for them, because the doctor is going to be like, I'd rather hit a home run in the next 2 weeks than collect information for a whole month and make her wait another month before figuring out what the issue is, okay? So be right and make people go through hurdles, okay? There's just a rule to live by. Make people go through hurdles so that you can be right. All right? More information is going to be better in this situation, not guessing. What's going to happen is you're going to find out a myriad of things. Number one, maybe her estradiol peak doesn't get high enough to actually cause release of a mature follicle. Maybe that doesn't happen. Well, what are we going to do? We're going to work on the FSH signaling pathway then. We're going to work on that. And it's usually inflammation that shuts it down, because remember, there's a positive feedback loop. Guess what usually isn't working? The positive feedback loop. Days 12 to 14. Days 12 to 14. You need to have enough estradiol to allow that follicle to actually come out and allow them to ovulate. This is so cool, you guys, all right? Like, this is something that makes me smile. And I'm not even talking about a specific patient here. This is something that makes me smile, because you're going to change somebody's life by getting them to ovulate effectively, right? Because you're going to get their stinking estradiol values up effectively because you figured out what the pathway problem was. The positive feedback loop usually doesn't work in this situation if they're not ovulating appropriately. How awesome is this? It means they have the eggs, they're just not getting rid of them. How awesome is that? What shuts down positive feedback loop? Inflammation. Inflammation. Absolutely. Inflammation. This is so cool. All right. What about the next one? What if they just don't create enough progesterone to allow the implantation or the maturation of the oocyte? That's what I call it. Right? What if they don't have enough progesterone? So what are we going to do? Are we going to look at what's stealing from progesterone production? Probably. What's that going to be? Stress hormone pathway, cortisol, looking at a pregnenolone steal, blood sugar causing all of this mess? Absolutely. 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 So this is the cool part with looking at all this stuff. This is so cool. All right, so when we look at these things, inflammation is going to be key. What have we talked about almost every week for the last 4 weeks? Inflammation. That stinking I word, inflammation. And so how do we process inflammation at a faster rate? It's by doing our functional analysis and making sure that we're understanding, making sure that we are keying up and teeing up, so to speak, the best possible program for your patient. Okay? It's critical when you're talking about female hormones, because otherwise what's going to happen is a patient goes to a primary care doctor, they go to an endocrinologist that deals with female hormones, and what happens is the doctor just loads them up on a bunch of hormone replacement therapy, and they're like, oh, now I'm on progesterone therapy. Really? How are you handling your stress? Well, I'm not. Okay. So you're just draining the tank faster now. Okay? Now I'm on estradiol, or the doctor, this one's crazy. I saw a lady on testosterone the other day. She had whiskers already, and she's on testosterone. I'm like, what are you doing? Doctor has you on testosterone because you have crazy cycles? That sounds like the worst idea ever. Like, I understand the logic of it, but it doesn't make sense when it comes down to the physiology, because the testosterone, they're using it as a negative feedback loop, basically. Okay, so like testosterone is going to shut off LH and FSH production. So they're using testosterone to shut it off like a negative feedback. And it's not helping because it's funding more of a blood sugar issue, right? So when all of this happens and we start talking about inability to detoxify, where do these hormones go? Where do they go? I don't know why I sounded like I was from Canada there for a second, but where do these hormones go? If you can't detoxify of them, where do they go? They go into your fat cells, right? You store them in fat-soluble tissue. Well, adipocytes. And if adipocytes are harboring hormone, and your patients come to you because they're trying to lose weight, how important is it for you to organize their detox pathways and then also their cycle? It is critical. It is critical. Man, back in the day when I was in college, working in the gym in like weight loss situations, there'd be some people that would lose 45 pounds in like 60, 70 days just working out like maniacs, right? There'd be some people that would gain weight 45, 60, 70 days, and they're still working out like maniacs. And one of the things that spurned me on to go to chiropractic school, and they got me interested in functional medicine in the first place, is that question right there. Why? How does that happen between these two people? They could have the same lifestyle, but why is this the case? And guess what it does? Is detoxability of these hormones. You can get somebody to lose weight if you figure out how to drain those adipocytes of their content. Because guess what your body's not going to want to get rid of when it's loaded with hormone in the adipocyte? You're not going to want to get rid of the fat that's buffering that hormone. Otherwise, you're going to be a toxic mess. You talk about migraines, okay? So think about that. Thin female with hormone problems, okay? And she gets migraines. Where are those migraines coming from? Toxicity. She doesn't have enough adipocytes to dilute. She doesn't have enough content in the adipocytes to dilute the hormone that she's not detoxifying from. So what do? Focus on those detoxification pathways. What gets regulated now? Her female hormone cycle. Not because you're doing anything cool or anything interesting, just letting the bathtub drain, so to speak, and the brain starts to participate again when there's more room for more hormone. It is so sweet. I just like to see this play out in clinical practice, because you're changing people's lives by reorganizing, making sure the orchestra is all playing the same song again. Okay? So super cool. All right, so this is like a quick 30-minute review, but the point is that hypothalamus telling the pituitary to produce FSH and LH. FSH and LH in the female, what are we doing here? LH, we're getting some progesterone production. FSH, we're getting some estrogen production so that we can mature the follicle and have release on day 14. What's happening is days 12 to 14, this is the monkey wrench in the review process here. This is the monkey wrench that nobody remembers. Positive feedback loop for female hormone pathway, days 12 to 14, which means that when the brain reads estrogen and progesterone present, positive feedback loop, the pituitary jacks up the LH and FSH concentration again and pushes more estradiol and more progesterone into the system, causing the release of the follicle. Now estradiol drops, progesterone continues to rise to allow the maturation or the implantation rather of that follicle. Now, when that happens, you want to be able to time your patient's symptoms to what part of their cycle are they dealing with. What part of their cycle are they dealing with? Okay, so if they're dealing with irritability, etc., at the front end of their cycle during menstruation, well, that's when their estrogen levels are at their lowest. Okay, what could they have? What type of functional diagnosis could they have? They could be estrogen resistant. Estrogen resistant, right? They could be progesterone resistant. Not a lot of information out there right now on progesterone resistance, but functionally speaking, you can see it happen. So if you can see it on the back end of their cycle, what's happening? Estradiol's dropping, progesterone's high, right? So like days 20 to 24, somewhere in there. If that's when you're seeing symptoms arise, what hormones are the highest? Progesterone. What do we got to do with it? We got to figure out if her body is actually dealing with progesterone or if the progesterone is not rising. If it's being shunted, the building block, the pregnenolone, is being shunted toward cortisol production because of a stress event. chronic stress, chemical, physical, psychological stress, chiropractic things. If that's the case, we want to be able to organize around that. So the female hormone map is so important for you to be able to draw out. Again, just Google it so that you have it. But map out where are the symptoms during the patient's cycle. And if they don't know when their cycle is, then that's where you got to start. You got to measure it. 30 days. Do the work on the front end. It'll reward you and your patient. And you're going to be in a spot where hopefully the lady that wants to get pregnant comes back and says, hey, you helped me get pregnant. And she can cry and you can cry because you know what? That's like a gift that you're giving somebody that nobody else is going to do it. It's a gift that you're giving somebody. So cool. So map it out, figure it out, do your best to be the nutrition hero in that instance. And it's just work. You can do it. All right. You've been listening to Nutrition Hero Podcast review, somewhat convoluted review of the female hormone pathway. Do your work, get it done, solve somebody's problem and change their life. You got it. Catch you next time.